LPA issues are fundamentally a little bit different than cholesterol issues.
Welcome to MedEvidence, where we help you navigate the truth behind medical research with unbiased, evidence-proven facts, powered by Encore Research Group, and hosted by cardiologist and top medical researcher, Dr. Michael Koren.
My name is Dr. Michael Koren, and I'm delighted to moderate another session of MedEvidence. And we're very fortunate today to have a special guest, Dr. Dennis Leahy from San Diego, who's going to talk about lipoprotein A from both the perspective of a clinical cardiologist, interventional cardiologist, and also a patient that has this problem. So it's a fascinating opportunity for us to dig in. And Dennis and I were just joking before I got on air here and stated, hey, this is two docs talking LPA. And so we're going to give you the opportunity to basically eavesdrop on our discussion. And you can see how two physicians who are really interested in the space, particularly the space of how to deal with this really, really, really bad cholesterol that we call Lp(a), and ultimately what somebody that has this problem, that has knowledge, is doing to deal with it. So with that introduction, Dennis, just tell the audience a little bit about your background and your passions in practice, and when you first found out about your specific problem with lipoprotein A.
Sure, happy to do so. I actually went to college and medical school on the East Coast, but then had the good fortune to come out to UCSD, where I have not budged since I arrived here in 1973.
Where'd you grow up?
Yeah, it was a good deal. So
I'm just curious, where'd you grow up? What part of the country?
I grew up outside Chicago, and then, as I said, 8 years on the East Coast, and then came here. So I was trained at UCSD doing my medical internship, residency, and cardiology fellowship, and then went into practice here and have been in San Diego since. Really started my practice or joined practice in 1981 as a general cardiologist who did caths, but as you know, interventional cardiology really kind of came along somewhat after that.
Right.
So did some retraining, having done a lot of work in the cath lab already, and went into the interventional space as well. So did general cardiology and a lot of interventional work. I actually continued in that practice and just retired about 6 years ago. But in the interim, I encountered my own particular vulnerability to heart disease when I discovered that I had high Lp(a). I'm a classic Lp(a) person in that I had a very strong family history of vascular disease. Probably came mostly from my mother's side of the family. I won't go into great detail unless you want to hear that, but she had a very strong...
I actually love to hear that. So just a couple of quick comments. Interesting. One is that interventional cardiologists often don't care about cholesterol problems. And so you're probably an exception to the rule. I remember when I was doing my cardiology fellowship a few years after you, the chairman of the program was skeptical about cholesterol issues completely, and was certainly not one that would push the idea that aggressive lipid control was really important skill for a cardiologist, which of course I found other mentors to follow with regard to my career path. But the fact that that you're an interventional cardiologist that thinks that cardiology is more than just fixing lesions is really heartwarming to me as a non-interventional research cardiologist. So I think that's really, really neat. But the other part to explore what you said is this family history concept is really, really important. So going back to my cardiology days, one of the things that struck me when I first learned about LPA is the really, really strong family history of people with this problem. So you'll get folks, for example, that have a father and mother who had some complications in their 20s, 30s, or 40s. And this is following each generation down the road. So, and to that point, I did my training at New York Hospital, and one of the famous LPA patients at New York Hospital was Arthur Ashe, who had this type of family history of having both mother and father have heart disease at a young age. And Arthur Ashe, as a fit professional athlete, had his first cardiac issue at age 29. So it was a very profound introduction to me of this particular problem. So yes, tell us a little bit more about your family history. When did your mom and dad first develop issues with their heart or vasculature?
Yeah, well, the family history thing is, as you said, it's a huge component of the Lp(a) story, and people who have high Lp(a), I think their risk has to be taken somewhat in context of their family history. And if you have the family history I have and the LP level I have, you're fated practically. But so I remember when I was growing up, I was probably about 10 years old, and my mother's brother, who I assume was maybe in his mid-50s then, had to have bilateral carotid endarterectomies. And I remember hearing that term. It kind of caught my ear because what 10-year-old would have any idea what that meant?
Right.
It was actually one of the first times I remember thinking, I kind of maybe would want to be a doctor because I want to know what that means more than anything else. But
so you didn't have other physicians in the family when you were growing
well,
up?
my grandfather, who I never met, he was predeceased my arrival.
Okay.
But
With
so
with atherosclerosis complications?
not sure actually.
Yeah.
That was
Okay.
a long time ago. But anyway, my mother's brother had it. My mother herself wound up having to have bypass surgery. She was living in Arizona at the time. She was probably in her late 60s. She had complete venous graft failure within 6 months and had to have a redo CABG when I brought her
Wow.
out to San Diego to have that done.
Hmm.
So that generation, I think several of her sisters had heart disease as well. The details are a little bit murky.
So let's jump into that a little bit, because I think that's actually very, very interesting from a number of perspectives. One, I don't know if you're willing or able to share numbers with people, but one of the questions that comes up is what your numbers are and what they mean, and the fact that LPA issues are fundamentally a little bit different than cholesterol issues. So, as we all know, for cholesterol issues, there's sort of a Gaussian-shaped curve of distribution of levels. And if you're at the higher end of the Gaussian curve, then you tend to have problems, but pretty much anybody within the curve gets some benefit by reduction of cholesterol. Whereas in LPA, it's an asymmetric distribution curve. And the people that are truly at risk are at one end of the curve. And that involves maybe about 10 or 15% of the population who have levels that are, 2, 3, 4, 5, even up to 10 times higher than what you would expect. So I don't know if you know those numbers offhand for relatives or for you, if you want to share that, but I think the audience might be interested in understanding that a little bit better.
Yeah, well, for the sake of accuracy, I'll restrict it to my own numbers. So in 2002, you'll probably recall, Lp(a) was known. I mean, it's been known as a lipid particle for some time, but there's a real struggle to figure out whether it's strictly a biomarker or a causative agent for vascular disease. And in 2002, things were every bit as murky as they were before that. But I was kind of a typical Lp(a) patient and remain so, in that if you look at me and you looked at 10 other people in the room, you'd say, who's the last guy here to get vascular disease? And it would probably be me. I've always been very fit.
Right.
I've exercised all my life and had virtually no other risk factors. So when I looked into my own situation, I had a maximal stress test that was normal. I got a basic lipid panel that had a, not ideal LDL. I think it was around 115, 120. Okay. But then I got a much more detailed lipid panel. And that was kind of the foreshadowing of my future troubles. My Lp(a) level was about 4 times the upper limits of normal. I had a CRP done that was elevated and a homocysteine that was slightly elevated. But we really didn't know what to do about any of that in 2002. Right. So I decided, well, I'm going to have a calcium scan, because then I've got to have a tiebreaker here in some direction of where do I stand right now. And I had a calcium score of 0.
Really? Wow.
Really.
Interesting.
And my risk calculation then, for a 10-year event was really, really low because all my other parameters were pretty normal.
Interesting.
5 years later, I started down what I describe as 10 years of vascular havoc. So
well, we're going to do a cliffhanger here. I love this story, actually. And so you had an LPA level that was 4 times normal, and we're going to actually explain what those numbers mean. And you had a negative coronary calcium count, basically.
Right.
And so the question is, are you really at risk? Right. So with that cliffhanger question, we're going to stop this part of our session and move on to the next.
Thanks for joining the MedEvidence podcast. To learn more, head over to medevidence.com or subscribe to our podcast on your favorite podcast platform.